make our typical side port incision with a MVR type blade. We hold the eye through the paracentesis and make a 2.8 millimeter clear cornea incision with a keratome temporally, keeping the wound peripheral with a usually a 1.5 to 2 millimeter tunnel. You can see that we fill the anterior chamber up with a dispersive viscoelastic to keep space, and then we will perform our typical capsulorhexis, trying to keep it approximately 5 millimeters so we can completely surround the anterior surface of the symphony intraocular lens with the anterior capsule. After the capsulorhexis is completed, we perform hydrodissection, that's injecting salt water underneath the anterior capsule to free the capsular contents, which is the cataract, and make sure we can rotate it freely. We use a modified Akahoshi pre-chopper to break the cataract into 4 pieces, as you can see here. We turn the nucleus with the pre-chopper, and again we chop it into 4 pieces, sort of forming a cross, making 4 equal pieces. We're going to use the Alcon Centurion phacoemulsification machine in this case, and remove each of the pieces of the cataract with a burst mode. This will use little bursts of ultrasound energy to grab the piece of the cataract, as you can see there. Then it will be sucked up into that tube in the phacoemulsifier and broken into little pieces. You can see we've taken the second piece out very quickly using the phacoemulsifier. This leaves us with a heminucleus, or half the cataract, to remove. We again remove this in burst mode, and you can see the piece of the cataract comes up very quickly. In fact, both the third and fourth pieces are still attached, and they come out as a unit. You can see we're left here with the last piece of the cataract, and we emulsify this very quickly using the burst mode and the high vacuum. After removal of the nucleus of the cataract, we're left with the cortex, which is a surrounding layer, and we'll remove this with a new irrigation aspiration tip I've been trying lately, called a polymer tip. This is one made by Alcon. I use sometimes instead of a silicone or steel tip, and it's fairly easy to remove the cortical remnants, as you can see here, and it's easy to get the subincisional cortex. These are disposable, and in my hand seem to work as well as the silicone tip or steel tip. This leaves us with these little capsular strands on the posterior capsule, which we'll remove with balanced salt solution here, just kind of hydrodissecting them off the posterior capsule. This is easy and safe, and I've used this now in probably 3,000 cases without any capsular rupture. We fill up the anterior chamber in the capsular bag with a cohesive viscoelastic, and we inject in the new AMO Symphony lens into the capsular bag using an injector and cartridge, and you can see that the intraocular lens delivers straight into the capsular bag. We make sure that the trailing optic and haptic are under the anterior capsule, as if they are above the anterior capsule. This will cause a pigment dispersion syndrome with the haptic or optic rubbing against the peripheral iris. You can see that we can hydrate the wounds with balanced salt solution in a 27 gauge cannula. Now we're going to remove the viscoelastic that is in the anterior chamber and behind the posterior capsule lens. It's important to remove the viscoelastic behind the intraocular lens, as this gives the Symphony lens or any intraocular lens a much more stable foundation to scar into place. You can see here we are ballotting or pushing down on the posterior capsule and posterior chambered implant to remove that viscoelastic sandwich between the two layers. You can see here